Well, hello, everybody. Good afternoon. My name is Garrett Schmidt. I am the managing editor and CEO of VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by Symbian Coding. And this is the first webinar we've done together, so very excited to work with these guys. And it is titled Mitigating Medical Coding Compliance Risk in Value-Based Care. And I got a little bit of a preview of what's going to be discussed today. So I think you are in for a very good presentation. A few items of note as we get started, or before we get started, rather. Everyone has joined today in a traditional webinar format. So it's a listen only mode, so you don't need to worry about turning off your camera, your microphone, or anything. That's been done for you. And we are going to have a time for some Q&A towards the end. So if you have a question at any point during the presentation, you don't have to wait until the Q&A to ask your question. You can go ahead and drop that in to your attendee module there. There's a place for questions. And we're going to get to as many of those as we can. If for some reason we don't get to yours, don't worry. Someone will reach out via email afterwards, make sure we answer your question. We do have a big audience today, so we probably won't get to everyone's. And finally, the session is being recorded. So what's going to happen is when we're done, about maybe an hour or so after the conclusion of the webinar, you will receive an email, and that email will have a link to the recording as well as to where you can download the slides and find out some other information there as well. So without further ado, I would like to very briefly introduce our speakers today. We have with us Mr. Gene Delva, and he is the founder and CEO of Symbian Coding. And then we have Dr. Jose Guthon, and he is a physician leader and value-based care expert. And we have Ms. Susan Wahlberg, and she is a compliance consultant for Symbian Consulting. So welcome all. I think, Susan, you're going to get us kicked off.
Okay, thank you. Thank you so much, Garrett. So let's get the next slide going here and we'll kick it off. And looks like one more. Okay, so what I'm going to talk about is really, I want to give you the high level, and then my colleagues are going to start getting more into some of the detail. My background is I'm a healthcare attorney and I do compliance work. So I'm looking at things from the compliance program level, and I do a lot of work with fraud and abuse and things like that. So that's my background, just so you kind of know where I'm coming from and where I'm going here. We want to talk first about basic compliance program requirements. And according to the OIG, there's the 7 elements. If you do compliance work, you're familiar with these. They're listed here on the presentation. I've kind of lumped them together, but policies and procedures, you need to have somebody responsible, training and education, auditing and monitoring, hiring and discipline, and then reporting and communications. Those are the kind of buckets that we want to talk about just briefly, just as a kind of a refresher. And if you're really more interested in building a compliance program, we're obviously not doing that here today. I've got books out on Amazon. You're welcome to go look at them. But that's just an overview. So let's move on. One of the key elements in a compliance program is to have the policies and the standards of conduct. These are so important because they really define the expectations you have for your employees. Also, it protects your organization. So if you have an employee that starts going sideways, you've got some vehicle by which to address that issue, right? You need to be able to do that for disciplinary purposes. Also, you want to make sure that your policies are all available for employees. You should have an intranet site or some other mechanism so that there's never a reason for an employee to say that they didn't know. And these policies need to be part of your training as well. So you define the expectations, you convey those. Key areas, and I'm talking at a high level here, billing and coding, contracts and financial arrangements, conflicts of interest, privacy and security, hiring practices, reporting and non-retaliation, and medical necessity. Those are some of the, from a compliance program perspective, those are some of the heavy hitters that really, they just have to be there. if you have a problem and the government comes and looks, you should have those things in place. Next slide. Another thing that's required, and there's various aspects to this, is to have a designated compliance officer. It's important to understand that you don't have to have a full-time person if you're a smaller organization. You can also contract this out. You can do it as a, any kind of structure that you want, but you're supposed to have somebody that is dedicated to overseeing compliance. You should also have organizational support, so a compliance committee. If you're small, that means, maybe it's your leadership team and they just designate time on your monthly meeting to talk about compliance. It can be that simple. Regulatory requirements are for having a privacy and a security official. Again, those don't have to be full-time. They can be part of a role. An important thing I want to note here, if you only take one thing out of the privacy and security conversation, is that if you have an IT vendor, that's not your security official. That's not your HIPAA security officer, unless it's in the contract. I've seen so many clients that said, well, we have an IT vendor. No, 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 no. If you have a breach, that person is not going to come and help you handle it unless it's in the contract, and they almost never are unless you request it. So be aware of that. It's a regulatory requirement. And then lastly, OSHA, we're not getting into OSHA, but that also has regulatory required responsibilities. Next slide. Training and education. I mean, there's not a lot to say here. Most everybody understands the need for that. Annual compliance training, new employees need to be oriented, and then risk specific. And I don't know if my colleagues are getting into that aspect or not, but certainly in the coding and billing and clinical world, there's an awful lot of training that needs to be kept current. So those are all important things and they need to be documented. I mean, me as a compliance officer, if it wasn't documented, it didn't happen, just like in the clinical world. Next slide. Auditing and monitoring, and this is another piece my colleagues might be talking about because that's a big piece when you get into the coding and billing world, medical necessity documentation, all those pieces. A lot of people don't understand the difference between auditing and monitoring, and the Inspector General does call out the need to have both. So I want to just clarify it. Monitoring is when you have somebody in your own office, maybe it's, for instance, a billing manager, that reviews the claims before they go out the door. You have somebody that reviews coding internally just to make sure that everything is, the documentation matches up and you've got what you need to have. An audit is a more formal process, and that would require somebody from outside of that department. So it might be a compliance officer if they have that skill set, or it might be someone you hire. Audits are important because even if you're doing monitoring, you might not know what you don't know. So maybe there was, a coding change or a new regulation, and for whatever reason, you didn't incorporate that or know about it. So if you have an external subject matter expert come in and kick the tires now and then, it goes a long way towards really giving you that assurance that you've got everything, all your ducks are in a row. So I can't emphasize that strongly enough. And it's not because, I'm trying to drum up business here. It's because it's a fact. It's something that needs to be done. Also, when you do have these audits or even monitoring reports, the compliance officer should be kept apprised, and there should be corrective actions documented and managed if you find a problem. So those are just a couple of key points about auditing and monitoring that do come up quite a bit. Next. Hiring and discipline. So the main thing everybody knows, I think, that you want to vet your employees and your business partners, right? But exclusion checking is something not everybody is familiar with, especially if you're a smaller organization or a startup, something like that. Exclusion checks are verifying any employee, future employee, or business associate, business partner is not excluded from participation in government healthcare programs. And there's a list of excluded individuals and entities by the OIG, and it's easy to find and it's easy to use online. Most states, if not all, also have similar lists, and that should be part of your hiring and contracting process. Like I said, not everybody knows that, but if you were to have an issue and somebody was billing things incorrectly or no, a variety of things, and you got in trouble and Medicare CMS came in to look, you could be in trouble if you have an excluded person that's performing those services. So that's a big piece of the hiring and discipline. That's probably my biggest point on this slide. The other thing is disciplinary standards. They need to be documented and they need to be consistent. And I'll give you a very fast example before we move on. If you have, for instance, your privacy and security requirements, maybe your organization just treated the mayor of your town. If you have two different people who snooped in that record, one of them is someone in your billing office and one of them is an employed physician, you can't pick and choose, how you treat those people from a discipline standpoint. You need to really think that through and follow your standards because it can create not just a compliance risk, but it can create a legal liability for you as well. Next. Reporting and communications. This is a quick one. Employees are expected to report any suspected or possible compliance violations. That needs to be in a policy, in a code of conduct, in your new employee messaging. That's just a key message that needs to always be there. The other one, non-retaliation. People need to understand that there's a non-retaliation policy, and they need to understand what that means. It's not just firing. It can be a whole host of adverse actions taken against an employee for reporting. So those are just some key aspects of the reporting and communications that are really important to understand. Next. These are just some high-level risk areas: HIPAA, privacy and security, contracts and vendors, and fraud and abuse, particularly False Claims Act. And just a note to stay on top of your new regulations and laws that come out, because you can have a risk area and not even be aware of it. So we're going to talk about a couple of these topics a bit more. Next. I'm not going to read through these in the interest of time, but from a privacy and security perspective, key things that get people in trouble are not understanding these things on the list, particularly business associates, and then the technical security requirements, one of which is that you have to have a security risk assessment. Those two things, if nothing else, pay attention to those particular items. That's where a lot of trouble comes. Next. Contract and vendors. This is a big issue in terms of enforcement. A lot of financial arrangements can be problematic if you don't know what you're doing. And I don't mean that in a negative way, but the laws are very picky, especially around referral arrangements. And if the contract is with physicians and you have potential Stark issues, you want to have legal counsel look at those agreements. That's not something that you want to get in trouble. And you need to be tracking them all, make sure your contracts are all fully executed and that everything is documented. Don't have it signed by one party and stuck in a drawer, in other words. Those things can create a lot of risk. Next. False Claims Act and the Fraud and Abuse. The False Claims Act, let's go to the next slide because we want to keep this moving. But this material is available for you. It's any person knowingly submitting a false claim to the government or causes to be submitted. The main thing for you to, well, there's a few main things, but one of them is knowingly. What does knowingly mean? It doesn't just mean that you know you're submitting a false claim. It can also be that you're being reckless. So, I think the term they use is deliberate disregard. It's important to understand that if you're just, not minding the store, that can be considered knowing. And the False Claims Act can be tacked on to pretty much any fraud and abuse violation and can result in treble damages. The other piece is one section that's known as the Reverse False Claims Act. And that part is if you don't repay identified overpayments. And this is a big deal. That means, back in the day, we used to just say, well, if we find a problem, we'll just fix it going forward. No, you have a duty to really analyze it, do an audit on it, and then look at what the repayments would be. At that point, if it's a big problem, you probably want to get an attorney to help you and make sure that you're handling that correctly, because if you just ignore it and go forward, that's when you're in violation here. Next. Okay, these are just examples to show that you don't have to just be billing claims to violate false claims. Okay, it can be a rebate that you don't properly credit back to Medicare. It could be cost reports, incentive payments, referral arrangements, a whole host of things. So that's my main point here, is that just about anything can trigger False Claims Act. Next. This is just another more detailed list. So you'll have this as something to refer to. Next. Anti-kickback statute, criminal penalties for knowingly and willingly offering, pay, solicit, receive remuneration. This is about referrals, and it's not purely clinical referrals. And there's cases here, but there's, IT vendors, different people have been found in violation of the anti-kickback statute. So keep this in mind when you think about providing goodies, rebates, discounts, freebies, tickets to sporting events are a no-no. There's a lot of violations out there. There's lots of millions of dollars in fines that have been paid. Next. This is Stark. Stark is similar to the anti-kickback statute to the extent that it's referral arrangements, but this refers to physicians. And the main thing is Stark is strict liability. That means that you don't have to even be knowing or reckless. If you violate that, you violate it. And it can be a detailed little thing that can be a violation. Have a lawyer look at your physician contracts. And that's kind of the bottom line on that. Next. The penalties, there's lots of penalties, and I don't need to read this to you, but the main thing to understand is that if you violate one, you can violate all, or pretty much, and they will prosecute it as a False Claims Act and give you treble damages. So, it just depends on the specific facts of what happens and what's done here, but it's just important to understand that there's a lot of potential problems that can come out. Fines, exclusion from Medicare and government programs, penalties, prison, obviously, that's not something most people are probably faced with, but it's just something to be aware of. Next. And I know I'm out of time here, so I don't want to run too far into it. I just have several cases here. The Halifax, this was one that was an $85 million case, and it was just contracts with physicians where the payments to the doctors was related to the volume and value of patient referrals. And it was that simple. I mean, of course, it's not that simple, but it's just a really good example. Next. Jelly Bean is on here because they were actually a communications design company that did a website for the Florida Children's Health Insurance Program. And that's just crazy, right? So they ended up paying $294,000. It was treated as a false claims case, but it was actually HIPAA violations. So that's just, I like to share this one because it just shows you that the government can get very creative with how they prosecute and fine people. Last, I think we got one last slide. modernizing medicine. This is just an example because this was electronic health records company, and they got in trouble as well. And the Department of Justice quote on that case is vendors basically will be held to the same standards of compliance we expect from everyone. So that's, I conclude it for that matter, because that's kind of a good message to all of us, no matter what our organization or role is. That's the government's view on it. And I think that's my last slide. And if it is, I'll turn it over to my colleague.
Thank you, Susan. Really appreciate it. Thank you for laying the foundation in terms of compliance, what needs to be done. Now, in my portion, my name is Gene Dalva, founder and CEO of Symbian Coding. In my portion, we're going to be talking about some of the most common coding errors that we have seen as medical auditors and what organization can do to mitigate these type of errors. First, what is medical coding? So medical coding, we can say, is a language that can translate what the providers are doing into standardized codes. Medical coding is the backbone of communication in healthcare. It is used for reimbursement. It also can be used for data analysis. Let's just say if an ACO wants to know how many patients with CHF, diabetes, COPD, all they have to do is to enter these ICD-10 codes, and then they will be able to pull that information. Coding is also used for quality measurements such as mammogram screening, blood pressure, and also hemoglobin A1C to see if they're controlled or not. Now, this slide shows the importance of having good quality coding data, because if the coding data is not accurate, now when you try to run your, that report also is not going to be accurate. Now, what are some of the challenges with medical coding? Well, there's a vastness and complexity of medical coding systems. For instance, ICD-10 diagnosis codes over 69,000. For ICD-10 procedure codes, more than 70,000. And then for CPT category 1, we're talking about more than 10,000. Not only that, every year they have to do an update. For instance, October 1st, they update ICD-10, ICD-10. So there were a bunch of codes they added, a bunch of them that they removed. So that shows the importance to stay abreast of these changes and to continue keep our knowledge current. This is on one side. On the other side, the information we're receiving from the providers many times are not accurate or incomplete or conflicting. So as medical coders, we have to know what we need to do when we don't receive complete information. Also, we deal with inconsistency in the documentation. For instance, and within the same practice, we may have two providers. They're not going to document the same way. Now, you can imagine if we're talking about a large corporation, a large health system, or ACO, when you have many different specialties or different type of providers, and a coder has to review this different type of medical records. Now, what are some common coding errors we have seen? Undercoding. Undercoding, this is when a provider bill for, let's just say, a level 3. However, the note supports a level 4. Overcoding, this is the reverse. They bill for level 4, and then the note only supports a level 3. Unbundling, this is when you have one code that contain many components. And instead of using that one code, they will bill for each component within that code, maybe sometime to increase reimbursement. Unsupported services itself, this is when they bill for something, and then when we check as auditor, and then we don't see supporting documentation, or there are some elements missing. This is very common for MSOs, inaccurate HCC coding. You have a patient either with a high risk score or low risk score, but that risk score doesn't match the information into the medical records. Let's talk a little bit about some of the unsupported services we have seen in ACO's value-based care organizations. Transitional care management, very common. A transitional care management is a Medicare billable service that helps patients transition from an inpatient hospital stay to a community setting to avoid medication error or readmission. Now, some of the missing elements we have seen many times, the date of discharge. Now, you may ask yourself why the date of discharge is important. Now we need to know the exact date of discharge. Sometimes we see patient was discharged last week or patient was discharged last month. We need to know the exact date. The complete date needs to be documented in the progress note. The reason is the reason that is something very important because we need to know if the practice actually contacted the patient within 2 business days of discharge. Without having a complete date of discharge, we won't be able to determine that. Also, we need to know if patient was seen for face-to-face encounter within 7 or 14 days. Another thing is that in order to bill for transitional care management, the progress note needs to be at least a moderate or high, means that at least it needs to be a level 4 or level 5. If the progress note looks like a level 3 and then you bill for transitional care management, that's not accurate. Let's move to another one, chronic care management. In order to bill for chronic care management, this is very common for value-based care organization. We need to see 2 or more chronic conditions documented, consent from the patient, and also one provider should be billing for CCM in a given month. Also, we need to see comprehensive care plan. That note should include the problem list, measure treatment goals, plan interventions, medication management. Finally, the time. Many times we view that progress note and then we don't see the time. And you might be surprised, many times we don't even have an actual progress note to show chronic care management was rendered for that patient. At least 20 minutes needs to be done to bill for a CCM. Just, best practice, it's not a bad idea to track the time to know exactly on that date I saw that patient and this is what was discussed, and then I spent 5 minutes. So that way, if there's an audit, you can go back and track instead of guessing to say maybe I bill for 20 minutes or 40 minutes. Here's another one, remote patient monitoring. This report came out about 3 weeks ago. And as you can see, and this report is from OIG. From that graph, you can see in 2019, they billed only for $15 million for remote patient monitoring. And then in 2022, $311 million. That increase is not just observed in traditional Medicare, it is also observed in Medicare Advantage. And according to the latest YG report, 43% of these remote patient monitoring are not supported. Why? Because they are missing the 3 key components. What are these 3 key components? The progress needs to show patient receive education. The device was set up. Also, the note needs to show the device was actually supplied to the patient. And also, treatment management should be documented, needs to be documented. Now we're going to move a little bit from CPT, we're going to move to HEDIS. Here's a very common one, mammogram screening. But you may ask yourself, what can be wrong with the mammogram screening for documentation? Many times when we review a note, they bill for the mammogram screening and then we see breast imaging or breast exam. That's not going to support a mammogram screening. The medical record should explicitly state a mammogram screening was done. And also the note needs to show the mammogram was done for screening or routine purposes. Finally, the date, the exact date, it is very important because if the mammogram is too old, we won't be able to submit it for these purposes. Now, let's talk a little bit about risk adjustment. On this slide, we only include version 24 instead of using a blended model, V20 and V24, just out of simplicity. So we only put the V24. Let's just say you have a patient, 76-year-old female patient is Medicaid eligible. They didn't do any type of chart review. The coding is not there. And then as you can see, the risk score gonna be 0.593. Let's just say they did some chart review, some coding, and then the risk score now increased to 0.948 because they built for diabetes without complication and morbid obesity. Now, let's just say they're doing a very good job. They capture almost everything. You can see now the risk score increased to 1.672. You can see the big gap when the coding is not accurate versus when the coding is accurate. This is why many organizations now, they have coders reviewing these records to ensure that all the conditions are submitted to CMS. They have CDI, clinical documentation improvement program, to ensure that they are getting the appropriate reimbursement. Now, if your organization has a clinical documentation improvement program, that's great. Just keep in mind, this is just a start. Why? Because having a clinical documentation improvement program can also lead into compliance risks. Why? Because if these coders or CDI specialists, they don't know how to query providers, that can lead into trouble. And the next few slides, we're just going to show you 3 examples what we are talking about. Leading query versus a non-leading query. A leading query, in essence, is when the coder or the CDI specialist is leading the provider into one direction, or the provider doesn't have enough room to exercise his or her own clinical judgment. That can put an organization into trouble. In this example, the patient has COPD and patient is on oxygen, and the coder asks, if you agree, please consider documenting chronic respiratory failure. That's leading. The coder is leading the provider into one direction. Now, the non-leading format, as you can see, same clinical indicator, and then the coder asks, does patient have one of the following: acute respiratory failure, chronic respiratory failure, hypoxemia, clinically insignificant, unable to determine? Because in reality, if someone has COPD and on oxygen, it may not just be chronic respiratory failure. Why the coder is leading the provider into just chronic respiratory failure? Is it because it's a risk-adjusted diagnosis? Is it because there's some reimbursement attached to it? So this is not the right way to do it. Here's another example. This patient has low EGFR, and then the coder asks, please document chronic kidney disease stage 3. In reality, the coder is telling the provider what to do, and that's not acceptable. The non-leading format, would you please consider documenting the clinical significance of this finding? Now, it's open-ended. It's up to the provider to decide to exercise his or her own clinical judgment to say, oh, that's chronic kidney disease stage 3. Here's the last one. Like, this patient has plaque in the lower extremity of the arteries, and then the coder asks, does patient have atherosclerosis of native arteries of extremities? You may ask yourself, but what is wrong with that? Because if you have plaque in the lower extremities of the arteries, it must be atherosclerosis of native arteries. Still, this is not the right way to ask the question. You need to give the provider room to exercise his or her own clinical judgment. The non-leading format: yes, no, other, clinically insignificant, unable to determine. This is the right way to do it. I know coders may have to spend more time to do the non-leading way. However, this is the right way it needs to be done. What are some ways now to mitigate some compliance risks associated to CDI or coding? Now, first, policies and procedures. As Susan mentioned in her presentation, training. She also talked about training, continuous monitoring, auditing. Someone should be checking to ensure that it is done appropriately. And finally, someone should be checking to ensure the providers themselves are engaged into the program, because if they're not engaged, that may not lead the organization where it's supposed to go. Let's talk about policies and procedures. The policy and procedures should define roles and responsibilities. Everyone involved into the process should know, this is my role as the CDI specialist or as the coder. The provider should know exactly what they should be doing. Also, the policies and procedures should show clear evidence-based standards to ask providers questions. It should be non-leading. And finally, the policy and procedures should emphasize ethical conduct. The coders, everyone should know, if I don't follow the rules, that may include disciplinary action or even termination. Another way to mitigate compliance risks is training for your coders, training for your CDI people. That training should be tailored to specific role. The training for CDI should not be the same as the training the provider is going to be receiving. Also, training should be ongoing, because we mentioned earlier, constant updates, constant changes to the guidelines. Or also, someone should evaluate the training effectiveness to ensure that the training is actually working. Now, if you're part of your hospital as a teaching facility, it is important to incorporate CDI training very early in residency, because when these providers now are on their own, they're gonna be very familiar with CDI. They know exactly what needs to be done. What are some things that should be included in the CDI training for CDI specialists? Coding and documentation guidelines. Very important, because if they don't understand the coding guidelines, the documentation guidelines, they won't know exactly what to do. Query best practices. They should be trained on how to ask providers things without leading them. Ethical conduct. They should know, okay, I want to get the reimbursement, but this is how I should do it so to avoid putting the organization into trouble. Communication skills. By communication skills, what we mean by that, many times coders don't really know how to communicate with a provider. Either they give them too much details, or they give them certain information our provider won't be able to process because they are clinicians. They are not coders. So they have to be able to break that information to a level the providers could understand. Now, CDI training for medical providers, that should include documentation requirements. For instance, the provider should know if I document diabetes, I should include the type, whether there's complication or not. If I document pressure also, I should also include the stage, so that way the coders can capture the accurate information. Query respond, they should know how to respond to these queries. How long they should respond? Is it 2 business days, 3 business days, 4 business days? And you might be surprised. Many times, providers are not even aware there's a CDI program in our organization. That's why they should be trained, they should be educated, so that way they understand this is why there's a program in that organization. This is why someone is asking me this type of questions. And CDI training for other staff. And this slide may not be applicable for all organizations. The reason is because if your organization is small, maybe you have the coder doing CDI, or that may depend. You may have biller also doing coding. The point we are trying to convey in this slide, whoever is involved into the coding process, CDI process, anything with reimbursement, they should receive some type of training. Depending on their level of involvement, it could be coding guidelines, it could be documentation requirements, and everyone should receive some compliance awareness training, because if they see something wrong, they should know what to do in that case. And finally, auditing. Someone should monitor what it is being done. And many times, many organizations feel very confident. They say, well, I have a very good coding department because we have a very high risk score for my risk adjustment patients, and they feel very confident. Now, it's not that complicated, but you have to know what needs to be done to pull a sample, check to see, okay, you have patients with high risk score. Can you support that? You have patients with very low risk score. Are you getting everything that you're supposed to be getting? And also check to see if the queries themselves are compliant. Are they leading or non leading? Check to see if the physician or the providers are responding to these queries. And also, you can use certain type of clinical key performance indicators to check to see, are you getting what you're supposed to get? Because if you have a clinical for a very long time, you should be able to see some financial impact. You should be able to see some changes in the coding practices. Now, when a value-based care organization put in place policies and procedures, training, education, and have somebody to check on a regular basis what is being done, those are a great way to ensure your organization is mitigating risk related to risk adjustment or to medical coding. Now we're going to turn it over to Dr. Gautam.
Thank you, Gene. Thank you, Susan. I always learn something new when I hear you guys speak. So um, I have a very short amount of time left, but fortunately, a lot of my key points have already been covered by my colleagues. Um, the physician's role in mitigating coding compliance really boils down to presenting a specific and clear clinical story so that the documentation justifies medical necessity. And this is also the hallmark of clinical documentation integrity. That said, let's look at these 5 concepts on the slide. The first one is somewhat self-explanatory, and that is proper documentation is essential for utilization, for continuity of care, particularly because we're in a fragmented healthcare system. It's important for transitions of care. It's important when multiple providers are taking care of the same patient. It's important for quality of care to capture and get credit for what we physicians are doing, and of course compliance. And I always say the struggle is real. And what I mean by that is that there are so many options, or excuse me, so many obstacles and challenges to getting the story correct that, and one of those is time. Physicians are pressed for time. Physicians have a number of distractions throughout their day. They're getting called out of the room. Something happens on the floor as they're in the middle of a note. And so it's hard to make sure that things all come together and that the clinical documentation is clear. Whether you work in a hospital, an outpatient clinic, or a private practice, the financial health of your organization is at stake because uh, how soon you get paid and how appropriate you get paid clearly depends on the level of the clinical documentation in the record. Um, Uncontrolled variation is the enemy of quality. You've heard that. That's a famous Deming quote, who was revered for his contributions to process management, particularly in the auto industry. But for many decades, we've recognized the same point in healthcare. And really, when you think about standardization and the development of clinical pathways and guidelines, really that's the sort of the wind behind the sails here, because we know that when there is variation in care, there are lower outcomes, poorer outcomes, and greater medical expenses. And finally, the physician's brain's not always connected to the pen. That's the famous Dr. Guiton quote. And what I mean is that physicians are processing so much information at one time. You know, the presentation, the symptoms, the history, and so what we're trying to do is process information to arrive at a differential diagnosis. Then we're processing additional information to try to narrow or refine the list to the definitive diagnosis. I'm not making excuses for inadequate documentation or poor documentation. What I'm saying is that we need tools to help us stay on track. And while we may not like physician queries, the reality is that we absolutely need them to help us get the clinical story clear. Next slide. Speaking of tools, here are some tools to do just that. I'm not going to go through all of them. Hopefully you've heard of most, if not all. I do want to just touch on one, and that's music, which may be better suited for the inpatient setting. And it's manifestation, underlying causes, severity or specificity, instigating factors, and consequences or complications. So let me apply music to a patient that presents with chest pain. It's very important to document the nature, quality, the location, duration of the chest pain. I remember moonlighting in St. Petersburg many years ago, and I see a gentleman who comes in and is very short of breath. And I ask him, do you have chest pain? Did you experience any chest pain? No, just I've been getting progressively short of breath, can't catch my breath. I examined him, and he has evidence for heart failure, I do a chest x-ray, classic heart failure. I go back to the room and I say, you didn't have any chest pain? Because it looks like you're in heart failure. He says, no, no chest pain, doc. So I do an EKG. The guy has inverted T waves in the inferior leads, suggesting an inferior wall MI. And I go back to the room, and now Dr. Gatun is very frustrated. And I say, you didn't have any pressure in your chest? He goes, oh, pressure? Oh my God, doc, like an elephant was standing on my chest, which is exactly how the textbooks describe cardiac pain. But I remember the words of one of my professors that always used to say, patients don't read your textbook. So you have to pry, you have to think the way they think. And so, again, it's important to document very clearly. Underlying causes, does the patient have anything that might make you think of pneumonia or respiratory process? Gastroesophageal disease, esophageal spasm can feel exactly like cardiac pain. Is there a history of recent trauma to the chest? Severity or specificity? Look, is it angina? You've got to make a confident diagnosis. Is it stable? Or is it accelerated angina? Is there any evidence for uh, a, a, ST segment elevation? If it's infectious, what is the organism that's most likely causing this presentation? And finally, consequences or complications such as arrhythmias, which commonly go along with cardiac pain, or evidence of acute valvular dysfunction. So if we follow the music, the clinical story can be clear and compelling in terms of medical necessity, and that will make our coders very happy. So use the tools to clarify the story. Next. I think both of my colleagues touched on this, and so I'm not going to make any further comments other than to say that I think in every organization, it's important to think about CDI and medical necessity from an ethical perspective, because they are in fact ethical matters, and everyone has the responsibility to get it right. Next slide. I think this is important, I say that CDI takes a village because it's important for the medical staff to understand the coders and the folks from the health information management team and the CDI team. If they know who these people are and what their roles are, then there's going to be greater collaboration and better communication and engagement. Communication is obviously important. I think that it's not only what we communicate, but how and when we communicate. If we send out an email blast and we tell the medical staff we're changing our policies or our processes tomorrow, that's communicating, but that's improper communication because you're not giving much notice. So, the more you can include your medical staff in these decisions, the more engagement and collaboration you'll likely have. Again, physicians need to understand the roles of the people around them, the folks that are sending them queries, and I think it just goes to more trust in your teams. Coding professionals need to understand that physicians are under that time constraint, that there's a lot of demands on their time. They're being graded by just about everyone. Their performance is being tracked. And so just be sensitive and respectful and making sure that goes in both directions. Let's go to the next slide. Well, the impact on patient care, after all, that's the most important thing here. Number one, clinical care. It's critically important to arrive at the right diagnosis because your treatment is not going to be effective if the diagnosis is not clear and on point. Documentation, compliant documentation recognizes comorbidities and severity of illness, which supports the most appropriate DRG payment and payment levels. There's a plethora of studies that show proper compliant documentation leads to better outcomes. And I just want to bet with my oldest son that I could include plethora in a presentation. So thank you for that. Compliant documentation is important to justify an inpatient stay. And there's that friction, right, between is this inpatient or an ob stay, and that's where the documentation really makes the decision. Proper documentation impacts public reporting of health outcomes, from quality scores to expected length of stays, quality measures, patient safety indicators, hospital-acquired conditions, et cetera. And finally, compliance supports KPIs such as risk of mortality and severity of illness. Next slide. So I want to thank you for your time. I apologize for going so quickly, but let me turn it over to Garrett, and he will help us with Q&A.
All right, wonderful. Yes, thank you all. And we do have a bunch of audience questions, so we'll get to as many as we can. Go ahead and ask if you do have a question, drop that in now, and we're going to get to as many as we can. First question is this. How can organizations establish effective communication channels to ensure compliance information is disseminated properly and understood by all stakeholders?
Is that for
Susan,
me or who's that for?
Susan, you want to take a stab at that one?
Communications, yes, absolutely. And it really varies depending on the size and nature of your organization. I mean, obviously, if you've got a small practice and everyone, has lunch in the same room, it's different than if you've got a multi-state health system or, very nuanced and far-reaching. But I mean, in a nutshell, I think, the best practice is to have a variety of approaches. So you want to have optimally some internal, newsletter. If you have a large enough organization, you have a compliance corner on your intranet site. Those are a couple of major things. Now, if you're a little tiny place and you don't have those things, you still need to have a dedicated compliance person. That person needs to get the message out to leadership team, to team meetings, to go to meetings with people, to make sure that they're engaging folks and letting them know. Send out emails, regulatory updates when and that's a key one because, changing laws and regulations are always a big risk area and a big challenge. So sending out emails to folks and just, like I said, dropping into meetings and just having it be a constant reminder. And also the open door policy, making sure everybody knows, like pop in if you have a question. So I think those are probably the key strategies for the typical organizations. Hope that answered it.
Yeah, I think so. Next question here is, and this is, I think, just an open question. What kind of clinical staff can do CCM? What credentials do they need?
CCM, I think in most primary care practices anyways, it's a medical assistant. If they have an LPN or RN, I think I would prefer those credentials. But I think that a well-trained medical assistant who the doctor has a close relationship and has trained himself or herself is adequate to provide the documentation under CCM.
All right, next question here is, what are the most common coding errors that lead to financial penalties in Medicare risk adjustment? Gene, you want to take a stab
Well,
at that?
yeah, thank you. We have seen quite a few reports from OIG about some of these coding errors. They call them high risk diagnosis. Lung cancer, many times patient had lung cancer, there's no active treatment. They just say lung cancer, and then when you check, you don't see any active treatment. Or sometimes you see just referral. Referral is not going to be enough to support any type of cancer. And also acute stroke. Just imagine a provider, a primary care physician submit a code for acute stroke, because if you have an acute stroke, you're not going to go see your physician. You're going to go to the ER. You're going to go to the hospital.
Yeah.
So 99% of the time, acute stroke from a primary care physician is not going to be accurate. Also, acute heart attack, because the guidelines, I think from ICD-9 was you can code acute heart attack within 8 weeks. Now in ICD-10 they changed it to only 4 weeks. So after 4 weeks is no longer acute MI, it's a old MI. So if people don't know that, they can bill for acute heart attack when in fact that will not be accurate, and that can lead to financial penalties from CMS. And those are just a few examples.
Sure, of course, of course. All right, we're running up on time here, but I have another question here for Dr. Gutton. What approach would you suggest in increasing the engagement of a provider who is nearing retirement in CDI?
Great question. Um, Challenging question. I would
Sure.
say, I would answer it this way. Look, I think physician engagement is a journey. It's a process, and that's why I've been very adamant about um, telling organizations and sort of preaching that CDI training needs to start very early, like as an intern, early in residency, and continue through their career. Um, it starts with onboarding new physicians that are coming new to the medical staff. And so I think it's that daily collaboration that builds the trust that increases physician engagement. For a senior physician, I would assume that there's some engagement there, but perhaps offering an opportunity to mentor a younger physician or a new staff member may be a good way to keep that physician engaged. And of course, I think it's sort of bestows an honor on a senior physician. We love our teachers and professors. So that's, I think, what I would do.
Great point. Well, unfortunately, and we do have a few more questions, but unfortunately, we are out of time for today. So if you have a question burning, go ahead and drop it in now, and someone, like we said earlier, will reach out to you to answer your question later on. But wanted to real quick thank you all for a fantastic presentation. Jean, Dr. Gutton, Susan, this was a lot here, a lot to cover in a short amount of time. So appreciate your brevity. But thank you all so much. As we close out, I wanted to encourage you all to head over to VBC Exhibit Hall, which is my organization, and we work closely with Symbion Coding, and you can see they have a virtual exhibit booth there where you can read up on them and what they're doing. You can really educate yourself on their services and offerings. And if you would like to learn more and of course contact them through there, you can do so. And also on bbcexhibithall.com, you'll see there's just a lot of great resources, educational resources on a variety of different topics. So feel free to go over there and check that out. And it's all free of charge. So yeah, nothing to lose there. And then finally, as we conclude, just if you would like to reach out directly to the Symbion team, feel free to do so. Their information is here on, there's info at symbioncoding.com, or feel free to reach out to me. I'm happy to facilitate an introduction as well if that is easier. But wanted to thank you all for spending your afternoon with us. I hope you have a wonderful rest of your week, and we'll see you on the next one. So have a good rest of your day. Bye-bye now.